So today we're going to be talking about AV canal defects. And what we mean by AV canal defects is partial or complete failure of septation of the outlet of the atria, the AV canal itself, the connection between the atria and the ventricles, and the ventricular inflows. So there's quite a bit of variability in the anatomy as well as in the functionality of the atrioventricular valves, as we'll see as we go along. We think this develops relatively early in gestation, just after the primary atrial septum and the dorsal mesenchymal protrusion begin to grow into the atria, forming the atrial septation complex that will divide the atrium, close ostium primum that we see here, and somehow is involved in fusion of the two principal atrioventricular cushions, the superior and inferior cushion. Here we're looking from the left ventricle, here from the developing left atrium. This is right atrium. This is the primary atrial septum and the dorsal mesenchymal protrusion, which grows in from outside. And these will further encroach upon the primary interatrial foramen. Here are ostium primum, and eventually in the normal heart close it. These are the two cushions from the left ventricle, superior and inferior cushions here. Now if we look a bit later, the dorsal mesenchymal protrusion here, purple, has grown into the space between the superior and inferior cushions, and they've fused together, they've closed. The primary atrial septum is back here associated with the superior cushion. And this results in two separate AV orifices, a right AV orifice here and a left over here. The two principal cushions that we saw before form the medial leaflets of the valve. The lateral leaflets are formed by the two lateral cushions, which develop a little bit after the principal cushions form. And so you can see this is from the ventricular side, the medial leaflets here in the right ventricle and left ventricle, and the lateral leaflets over here. And we think AV canal defects form relatively early, about stage 14 or 15. Here's the primary atrial septum, here's ostium secundum that's formed, here's ostium primum, and you can see that in this case, the dorsal mesenchymal protrusion here has yet to close ostium primum, has yet to fill the space between the two cushions. And we think that in AV canal defects, it never actually does. Here's an ostium primum defect or a partial AV canal. This is a complete AV canal down here. This is the foramen ovale. Here, the same thing back here, the free edge of primary atrial septum in both of these, and the AV valves over here. This is the superior cushion component and the inferior cushion component in an ASD primum. Here's superior cushion and inferior cushion in a complete common AV canal. And the dorsal mesenchymal protrusion here seems to be hypoplastic. It's hypocellular, and it doesn't grow in and fill the space and obliterate ostium primum. So we have a defect that results from ostium primum remaining open, and that's why it's called a primum defect, ostium primum defect. It's named after the orifice that remains. And in both of these cases, we have an ostium primum defect as well as some deficiency of the interventricular septum. And you can see the cushions, just like over here in the embryo, the cushions haven't fused together because the dorsal mesenchymal protrusion, which should come in here between coronary sinus and the fossa, hasn't filled the space. So that's what we think causes AV canal defects, or at least is a major contributor to AV canal defects. So we can think about AV canal defects as being partial AV canal defects or primum defects, where there's a common inlet to the valve, but divided AV outlet, divided AV valves. So functionally, there's only an atrial communication. And the potential ventricular communication is closed by the dense attachments of the AV valve onto the septum. These usually present like secundum ASDs. They usually have little or no in the way of symptoms, And if there are symptoms, it's usually related to AV valve regurgitation, left AV valve regurgitation, or left heart hypoplasia. We've seen a group of patients who do present with symptoms in the first year or so of life, and most of them have left heart hypoplasia, often with coarctation. On exam, the RV impulse is hyperactive because, just like what we talked about last week in secundum atrial septal defects, it's the same physiology basically. We have an interatrial communication, a pre-tricuspid left to right shunt. So this results in right ventricular volume overload. So the RV impulse is increased because it's doing more volume work. The second heart sound is usually widely split for the same reason that we talked about last week of maximally filling the right ventricle during both phases of the respiratory cycle. There's usually a systolic ejection murmur at the left upper sternal border from excess flow across the right ventricular outflow tract, a diastolic murmur along the left lower sternal border because of excessive flow across right AV valve. Does someone have a question? Okay. Now, in ASD primum, one of the differences is that we often hear a holosystolic murmur at the apex because there can be AV valve regurgitation, usually mitral insufficiency, in this case, or left AV valve, if you like, insufficiency. And so we get the typical blowing mitral murmur at the apex in some of these patients. The electrocardiogram is very helpful in distinguishing this from a secundum defect, and that's because there is a superior counterclockwise axis. Typically is upright in AVL, downgoing principally in AVF, so that the axis is somewhere minus 20, minus 30, minus 40 degrees typically in these. And then just like in ASD secundum, we see an RS big R prime in the right precordial leads indicative of right ventricular volume overload. The chest x-ray may be normal, may show cardiac enlargement and increased pulmonary blood flow, depends on really how big the shunt is. And we typically repair these in the first years of life because the longer they stay open, the more likely there is to be chronic mitral regurgitation from damage to the valve leaflets from regurgitant flow over many years that can cause thickening of the leaflets and make it more difficult to repair. So we usually try to get these done fairly early in life. The outcome's usually good. Mitral regurgitation is the one potential residual. This occurs, that's more than mild, probably in 10 to 15% of patients. And some patients, particularly ones with abnormal mitral valves, end up with a lot of regurgitation, sometimes or stenosis, and may end up with mitral valve replacement, although that's the minority of patients. These are older data, but I think it's probably only gotten a little better. Here's ASD primum. This is survival without re-intervention, and you can see it's on the order of 90% at 15 years. What this looks like by echo, here's a left atrium, right atrium, here's the primum defect here, here's the AV valve with attachments onto the crest of the interventricular septum right here, left ventricle over here, right ventricle here, here's the septum. And you can see there are attachments onto the crest of the septum, here's right ventricular outflow. So here you can see the defect adjacent to the atrioventricular valves. The rest of the atrial septum is usually pretty much intact. And if we look at this in a short axis view now, we're in more of a sagittal view with this superior vena cava here, inferior vena cava here. This is right atrium. This is the right side of the left atrium where the right pulmonary veins are coming in. And if we scan across, what you see is that we just drop off the edge of the atrial septum. Here's the atrial septum, and as we continue to scan to the left there, we lose it because we've gotten into the part where the primum defect is. And now we start to see the inflow into this, and then as we continue to scan down, you see the attachments onto the crest of the septum that these are what close any potential interventricular communication. So we have divided outlet of the valve down in the ventricles. So a common inlet, but divided outlet. So here's the common inlet up here. And then as we scan down, you see the attachments of the valve onto the septum and we have divided outlet into left and right sides. And with color flow mapping, you can see there's no interventricular communication. There's often some AV valve regurgitation here on the left side, left AV valve regurgitation going back into the left atrium. It's usually associated with the cleft, although there can be other problems with the AV valve. In an apical view, you get a very nice look at the defect. Here's the edge of the atrial septum that we saw before. Here's the defect, and here are the AV valves with attachments onto the crest of the septum. And that's what prevents interventricular communication. Once the valve leaflets close, there's no space down here for interventricular communication. And if we look at this with color flow, you can see that there's regurgitant jet through both sides of this valve. In this particular case, it's highly variable. There may or may not be much regurgitation. Sometimes the jets go at angles, like this one is going into the left atrium. Sometimes you see left AV valve jets going into the right atrium, so you can see a number of different patterns. The right atrium is here right-sided with typical pectinate muscle morphology. In the atrial septum, we see a foramen ovale here, and the ostium of coronary sinus here. Superior vena cava orifice is here. Opening the right ventricle shows the right side of this AV valve. The superior bridging leaflet is here with division and insertions onto the crest of the muscular septum. The inferior bridging leaflet is also here, inserted with multiple papillary attachments onto the inferior crest of the muscular septum. The lateral leaflet is here. The free edge of septum primum is seen here. This and the dorsal mesenchymal protrusion never grew in far enough to make contact with the AV cushions to induce them to fuse together and to divide the AV canal and divide the atrium, closing ostium primum. So we have a persistence of ostium primum, or the initial orifice between the two sides of the atrium in the embryo. And that's the reason that this type of defect is called a primum atrial septal defect. The septal band is here with papillary muscle of the conus. The pulmonary valve leaflets are supported by infundibular muscle and also separated by this infundibular muscle from the AV valve below. In the left ventricle, we see the smooth septal surface here with fine apical trabeculations. There are two sets of free wall papillary muscles here, the anterolateral set and the posteromedial set. The inferior bridging leaflet seen here inserts only on the inferior or posteromedial papillary muscle group, whereas the superior bridging leaflet here inserts only on the superior or anterolateral papillary muscle group. The lateral leaflet or mural leaflet on the free wall runs between the two papillary muscle groups. The cleft in the anterior mitral leaflet is here between the superior and inferior leaflet. Normally, this portion of the valve would fuse together and form the anterior mitral leaflet. But this doesn't happen in AV canal defects, allowing these two to remain apart. Typically, this is closed during closure of the defect to prevent regurgitation. The left ventricular outflow tract is seen here above the superior leaflet. There is fibrous continuity between the aortic valve and the superior leaflet of the common AV valve. The outflow tract is bounded by the interventricular septum above and by the superior leaflet of the AV valve below. if the insertions of the AV valve are quite high up on the interventricular septum, this can prevent the superior leaflet from moving away from the septum and out of the outflow tract during systole and cause subaortic stenosis. Here we see the leaflets of the aortic valve above and in fibrous continuity with the superior leaflet of the AV valve. This is a transitional AV canal. It's very similar to what we just saw, but slightly different. We're looking from the right atrium here. Here's the free edge of atrial septum. This is the fossa with a secundum defect. This is coronary sinus down here. So we're looking, here's right atrial pectinate muscle morphology here in the right atrial appendage. And as we now look into the right ventricle, see the outflow up here. This is the superior leaflet here. The inferior leaflet is down here. And there are attachments onto the septum that you can see here in the right side. And the outflow is up here with pulmonary valve leaflets there. Now, when we turn to the left ventricular side, what we see is the superior bridging leaflet here going to the anterior papillary muscle, the inferior bridging leaflet going to the posterior papillary muscle, lateral leaflet here. But there are small intertrabecular spaces. Let me just go back here a little bit so you can see this a little better. Here, here, and here, these are little intertrabecular, interchordal spaces that allow some interventricular communication. But once the leaflets close, these are the only points of communication between the two ventricles. So this is what's been called a transitional AV canal because it's transitional between a primum defect or ASD primum and a complete common AV canal where there are big interchordal spaces. So then that leads us to the concept of a complete common AV canal where we have a common inlet and common outlet, whereas in primum atrial defects or partial AV canal, as we saw, there is a common inlet but divided outlet. Here we have atrial and ventricular communications. Sparse attachments of the AV valve onto the crest of the septum allow for interventricular communications. Just imagine that little transitional canal that we saw before having much bigger communications below the plane of closure of the AV valve, and that's a common AV valve. And the interventricular communication is variable in size, going from this transitional with just a restrictive small interventricular communication to ones with very large interventricular communications. Typically in complete common AV canal, where there is a sizable VSD, these babies develop symptoms of heart failure, usually in the first weeks of life as pulmonary vascular resistance falls and pulmonary blood flow increases. They have poor feeding, poor growth, and we know that AV canal defects are associated with a number of syndromes, Down syndrome for one, heterotaxy syndrome for another. Ellis von Creveld can also have AV canal defects associated with it. On physical examination, excuse me, the precordium is very hyperactive because this is a big volume load, both atrial and ventricular, so it's a biventricular volume overload. There's usually a single loud second heart sound because the VSD is usually large enough to cause pulmonary hypertension in these patients. So the second heart sound tends to be single and loud. There's a systolic murmur at the left upper sternal border, again for excessive right ventricular outflow or pulmonary blood flow, and a diastolic murmur at the apex, again because of elevated flow across the AV valves. And particularly if there's AV valve regurgitation, then we are more likely to hear a diastolic murmur. As we said before with ASD primum, we can often hear a holosystolic murmur or a blowing murmur of mitral regurgitation at the apex or left AV valve regurgitation. These patients usually have big livers, but their pulses are usually normal. It's possible but uncommon to see coarctation with common AV canal defects. The electrocardiogram again has a superior axis here. You can see AVF is downgoing. upgoing in AVL, so this is even more leftward superior, more like minus 50, 60, something like that. And the other very characteristic feature of AV canal defects is huge mid-precordial voltages. This is V2 here, which is really quite strikingly large, this so-called Katz-Wachtel criteria for biventricular hypertrophy. And we see this in particularly in AV canal defects. You can see it in other things too, but this is one where we typically see it. Chest X-ray usually shows a big heart, a lot of pulmonary blood flow, sometimes even borderline pulmonary edema, and hyperinflation. Babies with big left to right shunts and a high PA pressure typically have flattened diaphragms and hyperexpansion because the little arterioles that run along besides smaller airways expand with the increased flow and pressure and tend to cause air trapping. And so you get sort of an emphysematous picture, air trapping with flattening of the diaphragms and hyperinflation. The repair for this is usually within the first 2 to 4 months, in part because these babies aren't growing because they're in heart failure, and also to avoid pulmonary vascular disease. Particularly babies with Down syndrome are at increased risk for developing pulmonary vascular disease. It's very uncommon, but some cases are too unbalanced to have a 2-ventricle repair. And some of these babies end up being staged to a Fontan operation, but most of them can certainly undergo a biventricular repair, even if it requires staging in initial palliation before completion of the biventricular repair. With common AV canal, the results, this is just a 1 year. This is months after repair. This is freedom from death or reoperation. You can see that at 1 year, it's about 90% in these patients. And this is freedom from more than mild AV valve regurgitation, or actually more than moderate AV valve regurgitation. And you can see by a year, it's about 80%. So more likely that they're going to have AV valve regurgitation. But survival is actually probably even better than this now. This is what common AV canal looks like. It looks a lot like ASD primum. We see the defect in the middle of the heart here on the subxiphoid view. Here's left atrium, right atrium. You can see the defect. But now the attachments of the AV valve onto the crest of the septum are a little more sparse. There's a little more space between the closure plane of the AV valve and the crest of the septum. And if we look at this in a short axis view, again, here's left atrium, here's right atrium. This is the plane of the septum. This patient appears to have a secundum defect as well. And here we've dropped off the edge of the septum into the ASD primum. And here you can see the common AV valve, superior bridging leaflet, inferior lateral leaflet in the left side of the heart here. There are attachments onto the crest of the septum, but they're a little more sparse. This is more of a transitional AV canal as well. Here you can see there are attachments here onto the crest of the septum. And if we look at this a little more closely and with color flow mapping, you'll see that this leaflet up here has attachments onto the septum, and you can see how it moves. It hinges at this point. Instead of just moving up and down, it folds at this point because there are attachments up there. Here you can see this leaflet on this side, this leaflet on this side, and you can see the hinging or folding up here on the superior crest of the septum. And it's really the superior bridging leaflet that we use to decide on what type of canal it is. I don't know how useful this Rastelli classification is today, but you can see this is what's called a type A because it has attachments of the superior bridging leaflet onto the crest of the interventricular septum. The inferior leaflet almost always has attachments, and so that's not what Rastelli used for his classification. It was the superior leaflet where we see much more variability. And if we look at this with color flow mapping, you can see that there are some little interventricular communications down here. It's not very big. This is probably really a transitional AV canal as well, but you can see there are a little bit. And there's not much AV valve regurgitation in this patient either. Here's a apical view, which is very helpful in figuring this out. You can see the closure plane of the AV valve is separated from the crest of the septum here, whereas in ASD primum, it's usually right on the crest of the septum. Here's the ASD component, or the primum defect component, and the ventricular defect component is down here below, where there are some attachments of the AV valve. They're just more sparse than normal. And if we look at this with color flow, you can see there's some AV valve regurgitation, but you also see flow here, this red jet, coming across through a ventricular septal defect here below the closure plane of the atrioventricular valve. So this is a type A of Rastelli, where the superior bridging leaflet is divided and attached to the crest of the septum. Oops. This is an example of complete common AV canal type A of Rastelli. The right atrial appendage here has typical pectinate muscle architecture of a right atrium. The interatrial septum is seen here with the foramen ovale, septum primum below, and septum secundum above. The ostium of coronary sinus is here, and the inferior vena cava entered the atrium here. The free edge of septum primum is seen to the left of the atrial septum. The dorsal mesenchymal protrusion and septum primum failed to extend all the way to the AV cushions and fuse with them to divide the AV canal. Consequently, we have a persistent common AV canal. Looking in the right ventricle, we can see the deficiency of the interventricular septum extending down into the inlet septum. This is septal band with the papillary muscle of the conus, infundibular septum here, extending to the free wall as parietal band. The pulmonary valve leaflets are seen above the infundibular septum in the outlet. The inflow portion of the ventricle is below the papillary muscle of the conus, or the medial papillary muscle. This is the superior bridging leaflet of the common AV canal. The left side is seen here in the left ventricle. There's a division here in the plane of the interventricular septum, and the right side of the superior bridging leaflet is seen here. It attaches to a free wall papillary muscle here in the right ventricle. The lateral leaflet is formed from the lateral AV cushion and is seen here on the free wall of the right ventricle. Another portion of the lateral cushion is here inferiorly, would form the inferior leaflet of the valve. The inferior bridging leaflet is seen here with dense attachments onto the crest of the interventricular septum. There is a wide gap here between the superior and inferior bridging leaflets. This sometimes needs to be closed to avoid regurgitation. In the left side, we see septum primum here on the left atrial septal surface, pulmonary veins entering posteriorly, and the left atrial appendage here, typical of a left atrium. The free edge of atrial septum is again seen here above the AV canal defect. The superior leaflet of the valve here attaches only to the anterolateral papillary muscle. The inferior leaflet attaches only to the posteromedial papillary muscle. The lateral or mural leaflet runs between the two papillary muscles.
The superior leaflet is divided in the plane of the interventricular septum, as we saw from the right ventricular side, and has numerous attachments onto the crest of the interventricular septum. This is typical for a type A of Rastelli. The inferior leaflet is almost always attached to the inferior crest of the septum, as we see here. There is sparse leaflet tissue here and large intercordal spaces. This is the ventricular septal defect component of the common AV canal defect. The left ventricular outflow tract is here, above the superior leaflet. The aortic valve is in continuity with the superior leaflet. The superior leaflet forms the floor of the left ventricular outflow. If the attachments onto the crest of the septum are high up, these can prevent the superior leaflet from moving away from the interventricular septum during systole and cause subaortic stenosis. This is an example. The large right atrium here with superior vena cava and atrial appendage. Septum primum has been torn here, but it forms the free edge of the atrial septum above the common AV valve. Looking into the orifice of the AV valve, the plane of the interventricular septum is here, dividing the valve into approximately equal right and left components. The right ventricle is hypertrophied. The superior leaflet seen here is undivided and unattached. It extends all the way across into the left ventricular free wall papillary muscle. However, in the right ventricle, it's divided here, not in the plane of the septum, but just to the right of the interventricular septum, and has insertions on a paraseptal papillary muscle. It then continues to the free wall, where it also inserts onto a free wall papillary muscle. But the division and insertion of the superior bridging leaflet to a paraseptal papillary muscle is the characteristic feature of a type B AV canal defect. The inferior leaflet is here on the inferior margin of the defect and on the inferior muscular crest, with multiple attachments onto the interventricular septum. The septal band is here, continuing as the moderator band and as the infundibular septum and parietal band to the free wall below the pulmonary valve. Pulmonary valve leaflets are here in the outflow, separated by infundibular or conal muscle from the underlying AV canal. In the left ventricle, we see the smooth septal surface, the fine apical tuberculations, and a pair of free wall papillary muscles. The anterolateral muscle receives insertions from the superior bridging leaflet, which again we see is undivided and unattached onto the crest of the septum. In fact, it continues into the right ventricle and inserts onto the paraseptal papillary muscle that we saw before. The inferior bridging leaflet here inserts into the posteromedial papillary muscle group. The lateral or mural leaflet here runs between the two papillary muscle groups on the free wall of the left ventricle. The left ventricular outflow tract is here. It's unusual to have subaortic stenosis with this type of AV canal defect because there are no attachments onto the interventricular septum. There's fibrous continuity between the
other type of AV canal defect. If there's an A and a B, there's probably a C, and this is it. Again, we are looking from the subxiphoid long axis view. Here's the primum defect, and here you can see the attachments of this AV valve are rather sparse, and there's a big space between the AV valve closure and the crest of the interventricular septum. We look in short axis. Now, remember before, this is the superior bridging leaflet here. Remember before, it attached up here when we looked at the type A, and it folded at this point. When it closed, these leaflets would fold right here. Watch this one and you'll see that the superior bridging leaflet just moves up and down as a unit. It has no attachments up here, and so it doesn't fold like that. See how it just moves up and down? It doesn't attach up here, doesn't have that hinging or folding pattern up here. It just is a common leaflet that moves up and down. So this is a type C of Rastelli. And if we look at that from an apical view, you can see there's a big interventricular communication here. Here's the closure plane of the AV valve. Here's the primum defect, left atrium, right ventricle, left ventricle. So this is a type C of Rastelli. And from a peristernal view, you can again see this large ventricular septal defect. And with color flow, we can see flow coming across the defect from left ventricle to right ventricle here during systole. So this is a large interventricular communication. And in short axis view, see the same thing, no attachments up here onto the crest of the septum. The AV valve is all down here, but a large interventricular communication.
This heart shows a complete common AV canal type C of Rastelli. In the opened right atrium, you can see the appendage here with pectinate muscle morphology typical of a right atrium. The superior vena cava, a small fossa ovalis here that's closed, we can't get through it, and the ostium of coronary sinus here in the floor of the right atrium. The free edge of septum primum is seen here above the AV canal defect. Looking into the right ventricle, we can see the septal band here with the Y and the infundibular septum inserted into it. The infundibular septum continues to the free wall as the parietal band. These infundibular muscle bundles separate the pulmonary valve leaflets above from the AV canal below. Here we see the inferior bridging leaflet and the superior bridging leaflet of the common AV valve. Here on the free wall is the lateral leaflet formed from the lateral endocardial cushion. Notice in this case that the superior bridging leaflet here extends from the left ventricle, from the free wall papillary muscle, all the way across the interventricular septum to a free wall papillary muscle here in the right ventricle. The leaflet is continuous and undivided and has essentially no attachments onto the crest of the interventricular septum. That allows the leaflet to move freely, or a free-floating leaflet, as it's often called. As is typical, the inferior leaflet has attachments onto the crest, inferior crest of the muscular septum. In the left ventricle, we see the free wall papillary muscles, anterolateral and posteromedial. This free-floating superior leaflet attaches only to the anterolateral papillary muscle, and the inferior leaflet attaches to the posteromedial papillary muscle. On the free wall of the left ventricle, we see the mural leaflet here running between the two papillary muscles. Again, note that the superior leaflet, except for this one small attachment, is undivided and unattached to the anterior muscular septum. This is the definition of a type C common AV canal of Brestelli. Again, the inferior leaflet is typically attached with multiple chordal insertions onto the crest of the septum. The superior leaflet is in continuity with the aortic valve here in the left ventricular outflow tract. This type of AV canal rarely has subaortic stenosis because the free-floating leaflet can easily move out of the outflow tract during systole and so does not cause obstruction. Note that there is a very large interventricular communication in this complete common AV canal. From the left atrium, we see the fossa, the atrial appendage here, and pulmonary veins entering the posterior aspect of the atrium. The free edge of the atrial septum is here.
So AV canal defects are typically repaired with closure of the cleft, or the space between the superior and inferior bridging leaflets in the left atrium. There was a time some years ago, largely due to concepts by Carpentier, who thought that the left side of the common AV valve should be treated as a 3-leaflet valve and not close the cleft. Turned out this was a bad concept. Here you can see these are data from some years ago. This was from 2000. So this is with the so-called zone of apposition, or what we would call a cleft, has been closed. This is survival. And this is with the zone of apposition or cleft left open. You can see there's quite a difference in the even early survival of these patients. Here you can see with the zone closed, it's 96% 1 month, 92% at 96 months versus 65% if this is left open. And that's because this results in significant AV valve regurgitation, and these patients have to go back and have it repaired. And that results in worse survival. And here you can see freedom from reoperation, same kind of thing here. Many of these patients, these are all survivors, but this is then months after initial repair. And you can see if you leave this open that by 10 years, probably 20% of these patients, or more, 25%, end up having to have the cleft closed. And in fact, in our experience, it's probably even more than that. So the outcome generally, as long as the repair is carried out with the current concepts intact, the mortality is quite low. It's just a few percent, and those are ones with very complex AV canals. Mild or moderate AV valve regurgitation is relatively common, probably 10–15%, and reoperation in 5 to 10% of patients for AV valve regurgitation. Now, there are some important anatomical features, particularly of the AV valve in the left ventricle, that are important for repair. And one of these is the papillary muscle anatomy. Normally in the left ventricle, we have 2 well-spaced papillary muscles and a well-formed mural leaflet that runs in between them. But in some patients, we have a single papillary muscle with essentially absence or marked hypoplasia of the mural leaflet of the valve. So the superior and inferior leaflets attach to the same papillary muscle. And in that situation, if you close the cleft, you can create a parachute or stenotic mitral valve. And this happened a number of times before we understood this particular complication. So here's an example of what the normal looks like. Here's the superior bridging leaflet, inferior bridging leaflet, and you can see this is the anterior papillary muscle, the posterior papillary muscle. Normally, the inferior leaflet goes to the posteromedial. The superior leaflet goes to the anterolateral, and there's a mural leaflet in between. And so that results in a 3-leaflet, basically, valve in the left ventricle. But we see some patients who have a single papillary muscle. In both AV valve leaflets, both the superior and inferior bridging leaflets go to this one one papillary muscle within the left ventricle. So here's the superior bridging leaflet, and here's the inferior bridging leaflet. And if you see, they both, here's inferior, here's superior, they both go to this single papillary muscle, which is usually more or less in the midwall of the left ventricle. And then if you close this, obviously you make a parachute, and this can create stenosis and cause problems postoperatively. So,
this is an explanted heart with an AV canal defect that is right ventricular dominant with a single left ventricular papillary muscle. Pulmonary artery is anterior and to the left, and the aorta posterior and to the right, consistent with normally related great arteries. Most of the atria, of course, are missing because this is an explanted heart. The common AV orifice is seen here with the right outlet into the right ventricle here, and the small leftward outlet into the left ventricle here. Note that the cleft in the anterior leaflet of the valve remains open. This was never closed because there's a single left ventricular papillary muscle, and this would create a parachute mitral valve. The right ventricle is markedly hypertrophied and dilated with endocardial fibrosis. The right component of the AV valve is here, with the superior bridging leaflet with attachments onto the crest of the septum there, and the inferior bridging leaflet here, again with attachments onto the septum. This AV valve attaches to a papillary muscle here in the position of the usual anterior papillary muscle of the right ventricle, arising from this large moderator band. The outflow of the ventricle is here, with the papillary muscle of the conus, the septal band, the Y of septal band, infundibular septum, and pulmonary valve leaflets above that. The left ventricle is here, posterior, and is quite hypoplastic. Notice that there is a single mid-wall papillary muscle group in this left ventricle that receives all of the insertions of this mitral valve. The cleft in the valve is here. The superior leaflet and inferior leaflet components of this parachute mitral valve. The left ventricular outflow tract to the aorta is here. You can see the probe there in the aorta. There is continuity between the aortic valve and the superior leaflet of this parachute mitral valve.
So that's one potential complication. And then, as we saw in that case, single LV papillary muscle is often, but not always, associated with left ventricular hypoplasia. But we can see alignment abnormalities of the AV valve with the ventricles. Most often, it's relatively balanced so that it sits, the common AV valve sits more or less equally above the two ventricles, but we can see situations, the most common misalignment of the valve is where the right ventricle is dominant. So the AV valve is aligned primarily with the right ventricle. The LV tends to be hypoplastic, and again, this is often associated with single LV papillary muscle. But we can see less frequently LV dominant AV canals where the AV valve is predominantly aligned with the left ventricle. We can look at this matter of alignment, often using a subxiphoid short axis view, and planimeter the area of the valve in each ventricle. Here you can see an example of that. We're looking at a short axis view. There's the part over the right side. There's the part over the left side. We just draw a line at the plane where the interventricular septum would be. And you can compare the areas of the two valves. And this can be very helpful in trying to figure out the relative balance of the AV canal. So here's an example where we have a right ventricular dominant canal, again, a single LV papillary muscle. And you can see this is the part of the AV valve above the left ventricle, and this is the part above the right ventricle. So this is probably 3/4 or more above the right ventricle and only maybe 1/4 over here above the left ventricle. So this is an unbalanced AV canal favoring the right ventricle. The way surgeons can often deal with this is just by how they place the interventricular septal patch. If you cheat over to the right side, you can in fact make the left AV valve larger by closing the VSD further to the right. In fact, this was a case that we published, other people have published the same thing. This was pre-op in blue and in red post-op. And this is just a matter of the surgeon moving where the VSD patch is. We also know that once you close the atrial defect and volume load the left ventricle, we see often a fairly dramatic increase in the size of the ventricle, in part because of the shape change. If you go from this shape to a more circular shape, it's a much more efficient volume container, and even without changing the circumference, you can increase the volume that the ventricle contains. But in fact, the ventricle does seem to dilate out relatively quickly. This was within a few days after surgical repair in this case. As I said, it is possible to see an LV dominant AV canal. Here's one where you can see almost all of this AV valve is above the left ventricle and just a tiny portion here above the right. There's a little bit of accessory AV valve tissue here that balloons up into the right ventricular outflow tract, but real AV valve tissue, there's just this little bit that's above the right ventricle, and most of this is above the left. This is uncommon, but we do see this. This is an example of a left dominant AV canal defect. And here we're looking into the right atrium. This is, of course, right atrial appendage. There's the atrial septum that's been divided. This is the right side of the atrium here, and the orifice of the common AV valve here after we divided the atrial septum. Here's right atrial pectinate muscles on this side, and on the other side, we'll see the left atrial appendage and left atrial pectinate muscles there. And you can see the plane of the interventricular septum is here in the middle, right there, with the right AV orifice on this side and the left AV orifice on this side. And you can see there's a bit of a difference in the size. This isn't so dramatic, but there's the right, and then the left AV orifice is on the other side. So there is a bit of a difference in the size of the two AV orifices. And if we look from the right ventricular side, you can see this is a type B. Remember, here's this big papillary muscle, and there's the bridging leaflet that's unattached to the crest of the septum there. It comes out over here into the right ventricle. There's the inferior bridging leaflet down there. You can see it's attached to the septum. And the outflow from the ventricle is up here. There's pulmonary valve, pulmonary outflow. Now, if we turn and look into the left ventricle, you can see that most of this AV valve is really sitting here above the left ventricle. Here's the superior bridging leaflet, inferior leaflet, lateral leaflet, and this is really the great majority of this AV valve. Only a small part was sitting above the RV, and the left ventricle is quite a bit bigger here than the right ventricle was on the other side. So this is an LV dominant AV canal. We can also see variation in the number of orifices. For example, here is a left AV valve with two orifices, one up here that's associated with the cleft and another one down here that's separate from it. So you can see two orifices. This usually results in some stenosis of the AV valve and makes it much more difficult to repair it.
This is an example of partial AV canal defect, or ASD primum, with a stenotic double orifice mitral valve. Here we see the opened right atrium with appendage, superior vena cava, and a small secundum atrial septal defect here between septum primum and septum secundum. The free edge of the interatrial septum is here on top of the AV valve. Looked at from above, we see the common inlet to this valve, the large right ventricular outlet, and a rather small left ventricular outlet. The tongue of tissue on the crest of the interventricular septum divides the AV valve into the two outlets. From the right ventricular side, we can see the superior leaflet and inferior leaflet of the valve with the tongue of tissue in between. The lateral leaflets are here. This is the septal band on the interventricular septal surface with the Y of septal band, papillary muscle of the conus, and the infundibular septum inserted into the Y of septal band. The infundibular septum proceeds toward the right ventricular free wall as the parietal band. Here we see pulmonary valve leaflets supported by the infundibular muscle and separated by it from the AV valve below. The left ventricle is moderately small. There are two free wall papillary muscles, the anterolateral and posteromedial. Notice that the superior leaflet here inserts into the anterolateral papillary muscle as well as the inferior leaflet. The cleft then goes to the anterolateral papillary muscle, and this is typical of AV canal defects with a double orifice. The orifice with the cleft almost always goes to the anterolateral papillary muscle. Within the inferior leaflet, we see that there is another orifice here that's inserting on the posteromedial papillary muscle. So there's another orifice to this valve that's within the inferior leaflet and is down here centered on the posteromedial papillary muscle. Notice again the cleft here between superior and inferior leaflets centered on the anterolateral muscle.
So you can have subaortic stenosis, as we've seen with common AV canal. Here's an example of that. Here you can see how the superior leaflet fails to move out of the left ventricular outflow tract during systole. And there's a little bit of a membrane that's forming here below the valve. So this is because of attachments. And if we look at this in short axis, here, you can see that there is an attachment here of the AV valve up onto the crest of the septum right there. And that's what narrows the left ventricular outflow tract. Here's the above, this is where the aortic valve is. It's quite good size up here. And as we scan back down into the ventricle, we'll go through a narrowed area there because of these attachments of the AV valve very high up into the septum. And there's the narrowed part of the left ventricular outflow tract. So this is how subaortic stenosis occurs. We can see tetralogy of Fallot with complete common AV canal. This is a known association. And you can get, here's the overriding aorta, right ventricular outflow tract obstruction, and a big complete common AV canal defect below. So TET canal is another possible cause. In here you can see the dynamic subpulmonary obstruction here from muscle bundles in the right ventricular outflow tract. Then AV valve function is the other issue. We can usually assess this in an apical view or peristernal view. Here's a subxiphoid view. This is an ASD primum. You can see the attachments onto the crest of the septum. Huge left atrium here, big left ventricle, and that's because there's severe left AV valve regurgitation. And we can look at that in a number of views and try to figure out exactly what the cause is. Usually it's through the cleft in the valve if the valve hasn't been repaired. But sometimes there can be additional defects in the valve, tethering of leaflet tissue to the posterior wall. So this is review of AV canal defects. Anybody has any questions, feel free to unmute and let me know.